Hi, my name is Jason Spangler, the CEO of the Innovation and Value Initiative. During the 5th annual IVI Method Summit, we explored patient-centered health technology assessment, or HTA, and charted its future course through discussions, methodologies, and networking with thought leaders. We aim to offer actionable steps for stakeholders to implement patient-centered HTA effectively. The 5th annual IVI Method Summit panel discussion, titled Rare Disease, Unique Needs, Adapting HTA for True Patient Impact. In 2023, IVI and EveryLife Foundation convened a PCORI-funded project on methods to identify common patient-centered outcomes across rare diseases. In this robust discussion, we will ask what makes patient-centered HTA for rare diseases different, and how can that inform HTA in general? This will feature as moderator Elisa Halpern-Paul from Venable, with speakers Dion Stalling from Rare and Black, Simu Thomas from Alexion AstraZeneca Rare Disease, and Annie Kennedy from EveryLife Foundation for Rare Diseases.
I wanted to, before we start our panel discussion, just do another call out of the body of work of IVI. IVI is not just all about convenings. IVI is about doing a lot of great deliverables and work. And so this is the one that I wanted to call out this afternoon. Annie looks familiar, right? So in IVI's equity work, rare disease is inextricably linked to the equity agenda. As part of that, last year, IVI and EveryLife Foundation convened a PCORI-funded project, the Patient-Centered Outcomes Research Institute funded project on methods to identify common patient-centered outcomes across rare diseases. So in all of your spare time, I direct you to this excellent piece of work. Again, the QR code that has been shared this afternoon will get you to this and all the other wonderful resources that have been referenced throughout the day. And so this next conversation is really going to be partially building on that body of work as we talk in the next 45 minutes about how patient-centered health technology assessment is unique to, and how rare disease is unique to, patient-centered HTA. So I'm going to now join you all on the stage. Before we go into our prepared questions, what I wanted to do is to spend a minute or two first finding out who each of you is, and then from there to reflect on this morning's conversation. So if each of you could do a brief introduction, but beyond what I just said, which was your name and your affiliation, what brings you to the conversation of patient-centered HTA? Why are you here today? And also what brings you to rare disease in particular? So Annie, we'll start with you.
For rare diseases. There we go. So if you talk slow, it starts. So I'm with the EveryLife Foundation for Rare Diseases, and I'm our Chief of Policy Advocacy and Patient Engagement. And it's, first of all, just really wonderful to be in this room with all of you and be learning from so many people. I learn so much every time I'm here. I've been in the rare disease space for several decades, and what first brought me to the space was I had somebody who I love very much, who when we were leaving college was diagnosed with a rare form of cancer, which at the time we would not have referred to it as rare. He was just told he was one of 3 people in the world who'd ever had it. And when he reached out to the cancer organization that we knew to call, they said, this has to be wrong because we don't know what this is. He was given 7 weeks to live. He actually lived for 13 months. But that was my first exposure to the world of medicine, to the world of being a caregiver, and to adult life. Really, I was 22 at the time and 23 when he died. I have a cousin with Becker muscular dystrophy, so I actually entered this world professionally in the neuromuscular space and have been in the space for some time and have worked with many of you over the years. And so rare disease is very personal to me. I also have a rare disease and have been listening to these conversations sort of through that lens. I'm diagnosed with a rare form of a more common disease. And so it's really interesting when you think about the data we collect and the outcomes we collect, because whenever I go back to my rheumatologist, I don't fit into any of the questions that are being asked because they're not designed for me. They're designed for a cohort of patients that are several decades older than me. So I'm really passionate about this, and I'm really delighted to be here, part of the conversation. And the first time I ever learned about HTA, I was working for an organization that had been leading a lot of the regulatory approvals around Duchenne, and we thought that the first approval for Duchenne would mean that we would have access to that product. And then we first learned about the acronym ICER, and was a part of those first regulatory, or those first interactions with ICER and with, at the time, NICE also. And so it was one of the patient groups that did begin to work with ICER and engage with an HTA and work on the modeling. And since that time, I've worked with a number of other groups that have been doing a lot of that same work with the HTAs.
I'm Dion Stalling. Excuse me, I'm sorry. I'm the executive director. Can you hear me? Okay, there we go. I'm Dion Stalling. I'm the executive director of Rare and Black. I created the organization. Our birthday was March 12th, 2020. I'm a rare disease patient. I have 9 rare conditions. The ones that most affect my life are chronic inflammatory demyelinating polyneuropathy, primary immune deficiency, and small bowel syndrome. I am here as a patient, an educator, because our organization does a lot of education around with the Black community, explaining to them that this is not normal, or this is not a old wives' tale. This is an actual illness. And I also serve on many advisory boards around research, cancer research, and making sure that Black people are at the forefront of how things are designed. And I'm also a parent. My daughter got diagnosed with Ehlers-Danlos syndrome 2 years ago, which made me, in her diagnosis, when her doctor was talking to me, I'm like, so me moving my kneecaps around in circles is like normal? I didn't know that that was a thing. I also have a 45-year medical odyssey, because I didn't get diagnosed with primary immune deficiency until I was 45. So I've been in the advocacy space since 2014 when I got diagnosed, and I'm happy to be here.
Thank you for being here. Simon.
Good afternoon, and thank you, Alyssa and IVI, for putting this very important topic to have a conversation on. One thing that pulls us all together, regardless of what your background is patients is the center of what we do. And our goal is to improve patients' lives, right? So thank you for inviting me to share my perspective. My name is Saimu. My day job is to run an organization within AstraZeneca's rare disease unit. So I'm responsible for health economics and outcomes research and global medical communication. I'm a pharmacist by training, turned into a health economist. I've been in the rare disease space for the last 10 years, spanning various therapies that we have brought to market. I also want to share, since I heard and was inspired, my personal motivation is also my wife, who's a rare disease patient. And just like many rare disease patients, people live with no treatment options, nothing proven out there. So there's a trial and error method, and we just watch and hope for something. And so the conversation we had earlier about option value and value of hope is very meaningful, because we wait to live long enough hoping that there'll be a treatment sometime in the future. And so I really enjoy this conversation, and it's very vital for our society.
Great. Thank you, all three of you, for sharing your personal connection to the topic. We had a lot of robust discussion this morning. And so before we dive into our prepared conversation, I wanted to ask each of you to reflect on the conversations this morning, starting with I'm going to call it our friendly dialogue. It was not foes. I think we landed in a good space between Christine and Mel. And then the two back-to-back panels. There was a lot in each of those. So welcome each of you just to share with all of us, what are a couple of things that really resonated with you, really kind of struck you, and that are going to stick with you when you leave here today? Again, from your perspective, from rare disease. So we'll go in this order: Simon, then Dion, and then Annie.
Okay, thank you. A couple of things I wanted to share. One is there was a question from the audience here. I think David, it was you who said, "What are we doing about it?" This is the same conversation we've had for the last 10 years, and I believe we have seen a lot of scientific progress, and we've seen several other panel members share different methodologies that we can adopt, and we can go through a long list of things that we can do. And so science has progressed to identify various elements. The situation that I think we should change is the mindset with which we have to adopt new methods and technologies, right? So oftentimes we are in HTA situations, because it's an HTA conversation, where we consider all value elements from a conversation perspective, but then when it comes to a decision-making point, we then go back to our old formulaic approach and say, well, it does not fit the formula and there is not enough evidence, and so based on our old formula, we will conclude as this. And that is the mistake that we are making. So what is it that we need to do to change our mindset to be open? And that is the biggest ask that I will say. It is a slow-moving machinery, but we have to be open. I want to conclude by saying, you asked us what is a good definition for HTA, and this is Simon's definition. It's not anybody else's definition.
Bring it.
So HTA is a comprehensive approach to evaluate the consequences of a technology to patients, healthcare systems, and society, to inform patient access decisions in a sustainable and equitable manner. So I want to emphasize that there are oftentimes elements that we take into consideration. We jump from HTA to cost effectiveness, and that is not necessarily true. There are various other elements that we have to consider, and when you're making a patient access decision, and ultimately that is our purpose. How do we propagate science and make sure patients have access to treatments that are coming out?
That's great. Make sure that's on your worksheet. Okay. Dion.
One of the biggest things that I remember was when Zubair said that he explained how patients who have depression versus not having depression fare better in their outcomes. We can never not discount the effect that mental health has on physical health. I can tell it with my own body. When I'm stressed, I'm in more pain. And the second one was the woman in the back that's the advocate that said that it's a holistic approach. The patient is a whole body person. And what I will take forward with me, because I work with researchers most in different parts of the country, is that we have to, when Mel said that they don't necessarily all the time look at the patient because they're looking at data, and it's not a bad thing. It's just that we as patients being able to explain to them the importance of what they're doing and how it affects, so that we can come to some happy medium, because there shouldn't be a disconnect between the two just because it's technical. And even though, science, data people are data people. People that are advocates are feeling people. Not to say that people that are doing data doesn't feel, but they don't always look at the softer side, or I call them the soft skills of medicine and research. So those two things, those three things stuck out, and that's what I'll carry most, because I work around researchers and they always wonder, what can we do, or how can we do this better? And how can we understand? And a lot of times is if you say something to them, they'll say, oh, I didn't know that, or I never thought about it that way. And that's why the patient perspective is so important.
Those are the great points. And I think that pulls through that theme of communication and it being bi-directional, right? Talking to each other, not just the researchers talking at the patients, and it's not just the patient sharing back the story, it's really having a dialogue. So thank you, Dion. Annie.
So, I mean, there was a lot this morning. I think overall, my first comment was, I think we've come a very long way from where we were several years ago, as far as the patient community working to transform patient experience into data and working together with methodologists to speak a common language, to your point, and figure out how we can bring the patient experience into models. So we're not there all the way yet, but we've come a very long way to figure out how our ecosystems can work together. And this meeting is a nice reflection of that. There were just a couple things that really struck me that I'd love for us to dig into more, or even going forward. One of them was the discussion, and it came up a couple times, around sort of how we reconcile what's good for the whole population versus what's good
Right.
for a subset of the population when we think about these HTA considerations. And one of the things that we in the rare community, and I know others, have been really working to do is to figure out how we quantify the lived experience and how we take some of those data elements, some of which we learn from in those ISA roundtables and in our exchanges, that are meaningful lived experiences that have not yet been quantified, and how we transform that into data. So we've been doing that. We published the National Economic Burden of Rare Disease Study. We just did a study on the Diagnostic Odyssey, but we've not yet figured out how to plug those meaningfully into HTA models. But what's hard is to quantify what doesn't happen. And so there have been some really important discussions here today around people not calling an ambulance, people not getting to a healthcare provider, people not pursuing healthcare, and how do we quantify that? But what I'm struck by, and what I struggle with, is we are already paying for negative healthcare consequences. We are paying for negative outcomes. And in the rare community, which is what this panel is about, we know that there are an estimated more than 30 million Americans living with rare diseases. And we know that that is a conservative estimate because we can't find everybody and so many people don't get a diagnosis. So we know we're paying for this already. And so I struggle with the struggle to shift the investment to improving healthcare outcomes from what we're already paying for. And so that would be one thing I would challenge us to talk about more. And then the last nugget I'm just going to leave on is, I loved, Kristen said it at the first panel, the comment around how she didn't use the term social isolation, but who you live with, where your situation is, your social situation is, as being a driver of health impact. And I can't get that out of my head, and I keep thinking about that. And I think that we need to think about how we incorporate that into our modeling, into the data we collect, even into the questions that a healthcare provider asks at the time of diagnosis. Do you live alone? Who do you live with? That is such an important determinant, but should also be a determinant about how we care for people and what we offer to them.
That's right. Those are all terrific. Thank you for sharing that. I'm going to go to the diversity of the rare community. I think if you've seen one person with a rare disease, you've seen one person with a rare disease. Even if you meet 10 people with that same rare disease, you have 10 different lived experiences, right? I really appreciated that Sneha lifted up this morning that she has a disease that if you're older, it's common, but if you're younger, it's rare. So even in her experience, even if she meets a bunch of, middle-aged people like me who are walking around with it, it's a totally different experience, right? So with this diversity, and we talk a lot about the value of diversity, right? Diversity, equity, and inclusion. These are all important values. They're part of patient-centered HTA. But diversity in rare disease can make it even more challenging, right? Because we don't have big groups of people to kind of do the math. Dion, you're saying, right? The data, like the sample sizes are so small. Given this diversity of the rare community, how can we ensure, I guess, if you will, or how can we try to ensure that we are, as we're creating these patient-centered outcomes, to point about, if we're spending money already, we might as well try to spend the money on improving people's lives, even if we can't cure them, right? The spend is already there. But in that effort to create these patient-centered outcomes, how do we make sure that that process is inclusive and representative of the diversity of lived experience? Because even when you're creating an outcome, right? Even if you're creating a measurement, an outcome to say, this is what good looks like in managing this disease, for 10 different people with a rare disease, they might have 10 different ways they might say to you, they're feeling good. So how do we, maybe I'll start with Simon as our scientist, or pharmacist turned, HEOR researcher.
So let me start by saying it is extremely challenging, right? But we have to try, because your question actually prompted me. As health economists, we all like to make population decisions, and so I asked a physician, okay, can you describe me a typical patient with a condition X? And they said, no, I cannot. And so how are we to then come up with an approach where we can summarize for the whole population? I would say the first is to acknowledge that there is variation, right? Every patient is different, and we try to summarize for the whole individual. And I think somebody earlier also mentioned there is no single rare disease patient with one condition, it's multiple conditions. So it is no longer assessing the condition, it is assessing the human. Now, we also have to be really careful in ensuring the measurements that we do have, we are borrowing from other conditions. So from a rare disease perspective, and we shared some examples here, there is always contradictions to overcome. One is patients are waiting desperately for alternatives. So we can't have the liberty of waiting for an endpoint to mature so that we can then prove the product is well or the impact on. So we have to have considerations of speed, development of endpoints, to showcase whether the product is working versus the ability to measure the full magnitude of benefit or harm, okay, of an intervention. And thirdly, we have to be extra careful to say, let's take a partnership approach to the future. We have some evidence of the product's impact on the disease or a condition. It is not fully calibrated to measure the full impact, but can we actually take it to the future? So my perspective on this is, again, I said it earlier, we cannot take a formulaic approach. We have to take a very consideration approach to say, here are all the parameters that we have to be thinking through, and what is it that we have to do as a partnership. I want to give two examples. One is in the area of myasthenia gravis. We asked patients, what are the things that really matter to you? And we summarized it through a project we call GMG 360. There were 8 different domains. How many did we measure in our clinical trial? 1, right? So how are we going to then convert the impact of the disease on the patient when we are trying to communicate the full story?
Right.
And so we have to be cognizant of that, acknowledge that, and then take that into consideration when we are making a decision. Let me pause.
Great, thank you. Dion and Annie, I welcome you to either reflect on or react to what Simon has shared, or just your own perspective on the question.
I mean, I might, okay, I might just add, I mean, there are some great examples of this work starting, just to add to the one that Simon already shared. So I had the privilege of getting to be a part of an effort that the University of Maryland School of Pharmacy led, and there are some people in the room that were a part of this as well, actually led it as well. And the goal was to look at developing patient-driven values through the lens of the patient community. And there were some community health partners that were a part of this effort that represented some of the communities that are often unrepresented, not just underrepresented, but unrepresented at the table for discussions like this. And it was really eye-opening to me as they expressed how not just culture that we talk about, but the political landscape and the variability of that will drive and influence people's ability and willingness to access healthcare. I mean, we've really talked about so many different factors. And then this effort went beyond just talking about disease specificity and the disease, but also went into some of those community health partners to talk to the partners, not just what does good look like, but what does bad look like, right? And why does good matter? What would you do differently with good? To sort of talk about how to tweak and how to determine what those values should be. And so I think it really does take, we've talked about it and several people in this room have said it, is finding some different new partners to come to the table with us and be a part of those discussions and then go out into the community. I know with the CMMI model, there's been some very meaningful partnership with the sickle cell community.
Right.
We then partnered with community health groups to understand what some of the data elements should be that are being collected and where does that data exist and does it even exist? And working with the sickle cell community and those community leaders to then figure out who the community partners were that they should be going into and figuring out what data there might be to inform those structures. So there is some really great work being done in this space and we need to learn from that work and then learn how to build from it.
Great. Dion, do you want to hop in?
They both said some really great things. The only thing that I wanted to add is, like when Ann said that there are different people that are not represented at all, and then there are some that are underrepresented. Also, Rare and Black, we did a small study with some patients in St. Louis. Age also plays a role in it. People that are above 55 in the Black community don't trust doctors as far as they can throw them. But you get younger people that are more apt to want to be part of trials. They want to, they want to be empowered, where people that are older, they've lived through things and they've seen things. And if I'm being honest, I think me hearing the stories of my grandmother having to go to a veterinarian versus a doctor to get a checkup in Mississippi before the Great Migration, and my grandmother saying we had to go to a vet to get our teeth pulled. And so if you hear that and then you see doctors and pharmaceutical companies coming in now saying, oh, we want to help you. Well, why do you want to help us?
Right.
And so doing that type of work with grassroots organizations. And this is also what I want to say. I don't know if this happens in this room. I've seen it, but I don't know if any of the representatives are here. When you make a partnership with an organization and somebody else is new and shiny and on a stage somewhere, don't drop that person to get on what's new and shiny, because the work is still going on. There is a huge the rare disease space is vast and wide, and she said it best. There are millions of people with rare conditions. Some are common, like sickle cell or multiple sclerosis or multiple myeloma, but then you have some that don't have any name, or you may have 500 in the country. But there's so much work to do I remember her saying this. I didn't go to Rare Disease Week this year, but there is power in numbers. And if you continually build your relationships, the rare disease space is small. Like when you start talking about rare diseases as a whole, a lot of us know each other. But when you start getting into disease-specific things, that's where the work comes in, and where people can be able to explain how this is affecting this patient population because of this illness and their needs are different, but collectively they're the same.
Right. Dion, I appreciate you sharing that. And I think it's a really important reminder that trust takes a long time to build it up, but it very quickly can be broken. And then it's really hard to repair it. And that there's a lot of bad history in this country that created understandably significant distrust and skepticism in the Black community and other communities, immigrant communities. I think, Annie, you're probably alluding to the political nature that some folks who are undocumented probably don't feel comfortable seeking healthcare they need because it may not feel safe to them, right? So we have a lot of work to do. But Dion, I really appreciate you pulling through that theme from this morning about trust and partnership and dialogue, because it's incredibly important, and it can't be transactional, to your point. It can't be a one-hit wonder. It can't be, oh, I'll give you a little bit of money, we'll do something, then I'm on to the, as my kids say, the BBD, the bigger, better deal, right? Like, no, you got to dance with the one who brung you. Like,
Exactly.
build that relationship and then build out from there. It's an and, not an or, is what I heard you saying. I also want to build on Annie and Simon, what you were saying, which is this takes time and this takes intention, but it's work worth doing, right? And we're making progress. It's not going to be fast, right? But we're chipping away at it, right? 5 years ago, I remember at the first summit, right? It was the first real conversation. IVI was just created as a nonprofit organization, right? Here we are 5 years later, and we're talking about mixed methods. We're talking about, or I'm at least talking about, imputed data. Now I really sound like I know what I'm talking about, right? And we have ways to do some of this work. What we need to do is really accelerate some of these efforts. And Simon, I heard you saying that some of it is about mindset. And I think earlier today, we heard Anton say culture. And so I think it's culture and mindset together, along with just sheer will and grit of this community, folks in this room and on the Zoom, that will hopefully kind of accelerate us through. I got the sign that I can ask one more question before I have to open it up. So I'm going to do that, which is, as you were listening to the real option value, and you alluded to it in your opening remarks, Simon, but as the three of you were listening to that conversation on real option value, what was going through your mind in relation to rare disease, right? So we talked a lot about cancer. Cancer is a good and common example, and I think the work that Dr. Lee has done, and award-winning work, I might add, in that space is really important. And we know that if we can do it in cancer, I worked at the American Cancer Society a very long time ago. If you can get it done in cancer, then often that's a model that we can then take it and use in other conditions. But there's some things that are unique to cancer or make it different. It's so common, cancer generally, there's very rare forms of it, as Annie lifted up. But when you think about rare disease, and you listened to that conversation earlier today, did anything go through your mind of either, aha, that's great, or yeah, that won't work for the rare disease community? I'll start with you, Annie.
Well, I said some of it in my question, so I won't repeat that. I think rare is very difficult. We have very small communities, and we have some communities who've benefited from our existing therapeutic development models, and we have some communities who've still been left behind. And so I actually, when I think about this petal of the value flower, I think it actually speaks to some of those communities who've still yet been left behind. And we definitely have to start someplace for our communities. And we have to be able, I really do want to underscore, to measure the value of starting someplace. And what are those additional benefits of slowing disease progression, alleviating caregiver burden, reducing the additional costs in rare disease, in the lived experience of rare disease, enabling productivity. We have to bring all of that into the equation. If we don't start someplace, we will not open up the field for those who come next. I also think that connectivity between rare diseases is incredibly important. And I think that also is addressed in that petal of the value flower.
Great, thank you. Dion.
I was just thinking that there are so many different social determinants of health when you think of underserved people, not just who you live with, but who do you live without? Like, where are you? If you're in the boot heel of Missouri and your closest hospital that treats your illness, or as a matter of fact, a really good friend of mine in a rare disease space, he sees a doctor at Washington University, but he lives in Virginia and they've never seen each other. Like, understanding, and the doctor sees him for free, right? Because his insurance is out of network. And the doctor created his own company to build an organization to help him pay him and the test. This shouldn't be. So even though the diseases are different, people's circumstances, as we've said over and over and over again, are different. And when we understand it, I don't know if we need to go to the C-suite to make hospitals understand that. And I know this is not a policy thing, but it all ties in because everything is so different. I heard a woman recently, we were on a call and we were talking about Medicare Advantage. And she was like, well, people shouldn't get Medicare Part C because it's only like, they only give them $150. The only difference is regular Medicare and this is they get $150 per month for over the counter. Well, if you can pay for your groceries for $150 a month versus you're in the red for a rare disease, it's worth me paying or being dual eligible for Medicare and Medicaid for me to be able to get some help for my rare disease and me being able to eat food. So I think we need to pay attention to all the aspects and in every single case. And if you see something, say something.
That's great. Thank you. Samu.
I want to piggyback on what Annie said about University of Maryland. It's a fantastic school, not because I just went to school there, but I think we have some professors over here. But
Go Terps.
It's a fantastic question. I think when it comes to rare and value frameworks, HTA, we really have to go back to why are we doing this? What is the purpose of doing an HTA? And that could be different, right? Are we looking at a budgetary limitation, or are we looking to balance scientific progress, budgetary consideration, but also increasing options for patients who have no options? So we have to look at it very differently. When it comes to endpoints, we have to be conscious about the meaningfulness of endpoints to patients. And I always am blown away by one of our patient advocates would come and say, you're measuring all these things in a clinical trial, but I want to make sure that my son or daughter can go to the bathroom by herself or himself without my help. How can we measure that, right? And so the lived experience can mean different things.
That's right.
Meaning related to different conditions. I will say when it comes to options and so on and so forth, we have to broaden the scope. And it's a tall ask, broaden the scope in terms of healthcare system value and beyond healthcare system value. We have to talk about patients' value versus societal value, which is actually very meaningful because it links into option value. We have to talk about equity as a central principle when it comes to rare diseases. And it is a very highly marginalized community. And we have plenty of work that shows that interventions work really well. But then why do we have a situation where marginalized community are doing poorly? So we have to change our perspectives. And let me conclude by giving a little bit of a statistic that maybe helps us to reverse order the formulaic approach I was saying. Let's consider a rare disease with 3,500 patients. And one would say, yeah, you need a clinical trial, say 100 patients to prove some value or benefit or harm. So that is representing about 3% of the whole population. Okay. Now let's take diabetes. Diabetes, I think it's about 550 million patients. And if you take 3%, it is 60 million patients or subjects in a clinical trial. And one would easily say that doesn't make any sense to have a clinical trial of 60 million. So I'm just giving you an example of reverse principles where sometimes we tend to take a common approach and apply to rare, and which is not meaningful. And this is a reverse. And I was sitting here in the morning, how do I communicate this? And I'll give you a poor example, which is we've been measuring how do we value gold, okay? And we have carats and weight and so on and so forth. Now we have a diamond. Both are very good and very important. Do you use the same principles? Do you use the same tools? Do you use the same instruments? The answer is no.
Right.
So we have to think about it very differently.
I love that analogy, not just because I like jewelry, but I thought that was great.
in particular, I want to just lift up before we go to audience Q&A, the meaningfulness of endpoints. And the meaningfulness of endpoints to patients or to caregivers or to the trialists or the FDA. Annie and I cut our teeth together working with the SMA community, spinal muscular atrophy, and I will never forget there was a young adult living with SMA, and I got to know him, and he said, I don't think I'm ever, because he was already in a wheelchair, and he said, I don't think I'm ever going to be able to walk. This is before FDA approval of treatments for SMA. He said, but I want to always be able to pull open the fridge myself. The fridge can be pretty heavy, right? And he said, if I could still, in 10 years or 15 years or 20 years, I don't have to walk, but if I could still pull open that fridge, that's a win for me. Now, do you think there's a clinical trial that has as an endpoint, can pull open the fridge? No. But to him, that was a clinically meaningful endpoint. And so I think it's incredible. But can we turn that into an endpoint that the FDA would accept and that we can then plug into HTA? Probably, but it will take some time and intention, but we got to do it. Annie.
I think tying endpoints to meaningfulness, I mean, in the context of HTA, I guess it would just be interesting, and maybe somebody in this room has done it or somebody listening has done it. But, you know, when you're talking, what makes me think about when you're talking about the parent who said, I just want my child to be able to use the bathroom independently. You know, you can measure stability and the ability to sit independently.
Right.
You know, throughout my 30 years in neuromuscular, a really important inflection point is when somebody loses the ability to transfer themselves, because that then speaks to the amount of time you need with a caregiver, and whether you need a caregiver to help you in and out of a chair, in and out of the bed, or at work. Your ability to turn yourself at night, your ability to go up and step, whether you're young or an adult, that speaks to curbs, going in and out of people's homes, your safety in the street, whether you can go to a sleepover at a friend's house.
Right.
So there are some endpoints and outcomes in clinical trials that correlate to how big or small your world gets. And it seems to me that they could be weighted within the HTA setting by patients, by the subpopulation that was in the trial, to say this, in a similarly how we weight things to the clinical meaningfulness in the regulatory setting, what is the clinical meaningfulness, the real world meaningfulness of this in the real world environment to you?
Right.
And I think that that's some of the work that we should think about, is taking those endpoints and saying, but what does this translate to? What does this mean for the cost of caregiving, the impact on all of the people in your world, and you as the person in the center of that ecosystem? What are you now going to be able to do if this gets expanded?
Right. That's great. Thank you. I'm going to pause. First, see if we have questions or comments from folks in the room. So we have Rich. We need to get Rich a microphone. Rich, introduce yourself.
That's easy.
And affiliation.
Yes, the microphone works. I'm Rich Brennan. I'm the Vice President of Federal Affairs at the ALS Association. So I appreciate being a part of this great conversations today. And I was telling Annie that a lot of what she said already so far is what is percolating at the top of my mind. When I'm thinking about HTA, and it's more of a cautionary note, is what is it? What is the effect on innovation? And can we over-prescribe or be too prescriptive because we're trying to be cost-conscious, we're trying to be outcome-oriented, so on and so forth. So to give a for instance, in ALS, which is a neurodegenerative disease, very fast progressing, most that are diagnosed with ALS live 2 to 5 years. They have already assumed that their one and only chance in a medication will be just on that life cycle. They're already assumed that whatever they participate as far as clinical trials is going to be something that is passed on to another generation of somebody living with ALS, because they're not going to survive that. So with that said, they're willing to accept more risk. That's already assumed in our clinical trial work. With that, there's learnings that comes from failures. We've had a failure even recently of a therapeutic. But there's also learnings from successes that we have. And so we're trying to be very cognizant at the ALS Association about how can we shorten timelines, meaning that anything that is a success on the research side can be directly informative to the clinical side, shorten those timelines, and also, again, operate in an environment where, yes, we have to take risk, and we have to assume that there are risks taken, and that people that assume that they are part of a place where we can make ALS a livable disease assumes that we have to make sure that we do everything possible to provide flexibility and in experimentation and how we go about curing an incurable disease so far. So sort of a statement, but I welcome anybody's opinion on that as well.
Thanks, Rich. Appreciate that. I'm getting the sign that we are, how quickly that went, man. Before I wrap it up, I want to just honor and see if there's any questions online that we have for the panel. Melanie?
I do have an online question. This comes from Ellen Schultz, who's a consultant that works with IVI. And she asks, we've heard a lot about the challenges of HTA for rare disease, but are there also some hidden opportunities? What might be possible with such a small and closely knit communities that could spark innovation in assessing value of rare disease treatment options?
Great question. I see at least two nodding heads, so I'm going to give you the 30-second. Can you give a quick 30-second answer, and then Annie? And then I want to honor that we want to keep everybody on time. So
Maybe it's a summarizing comment that HTA should not stand in the way of patient access in rare, but it should inform.
great. Thank you. Annie?
Yeah, I would just, Mel gave some really nice examples earlier of, new data elements that could be incorporated into modeling. I guess I would just challenge us to be incorporating them earlier into modeling. I think sometimes we come up with those questions or those opportunities late in the assessment, or sometimes even at the roundtable. We think that would be a really great thing to capture. And I would challenge us to be incorporating those earlier.
That's great. I think that's one of our other themes, which is move everything upstream. And to Dion's point earlier, upstream with patients from the beginning and transparent about the conversation and what's realistic and what's not. So please join me in thanking our three terrific panelists. Thank you. Thank you.